We'll first begin with talking about preparing for the ABOS recertification examination. Here are my standard disclosures. I have three major goals for you in this lecture. I want you to be able to understand the question format, learn a test day question strategy, and then establish a preparation plan so that you can be successful in passing your recertification. The first topic is understanding the question format. And since most of you have not taken an examination in orthopedics before, since you took your OITE, I thought it was an important thing to begin by discussing how the ABOS compares to the OITE you took 8 to 10 years ago. The ABOS examination, the recertification examination involves longer questions. It's more likely to involve patients. They all follow a same basic outline. They typically have different lead-ins than those you may have seen in the OITE, even those if you've been taking them religiously over the last several years. There are more options to choose than the standard 5 that can appear on the OITE, and they have a couple of different formats, including the multiple item format and the sequential item format. Beginning here, here's a typical question of something that you would see on the examination. You can see that in this question here, there's at least 200 words and about 8 sentences long. And there are also more than the 5 standard options. The format takes a standard approach, and this is based on a standardized approach produced by the NBME certification board. And this is very useful to understand this question format, because if the question is as long as 200 or 300 words and you only have a short amount of time to learn or get through the question and learn what it's asking you, then you want to be able to identify information in a reliable format. And this is going to follow the exact same format that you would have followed when you were a resident presenting to a staff. So it will start off with a 45-year-old man. It'll give you the site of care, what the chief complaint is, and potentially how long it's been going on for. You'll then find some physical findings, and then you'll go maybe with some diagnostic studies and maybe some initial treatment. And that's going to be a standard format for almost all the questions that you see on the examination. The lead-in, which is the very last sentence to the question, is going to follow the very similar ones that you may have seen and remembered from your USMLE examination. And again, the USMLE and the recertification are both prepared by the National Board of Medical Examiners, or at least proctored by it. And so that's why you'll see very similar things, such as which of the following is the most appropriate next step in the evaluation of the patient? What is the most serious acute complication of this injury? And what is the most likely explanation for these findings? These are typical questions that they will ask you in your recertification examination. As I mentioned earlier, there can be up to 20 or 25 or even 30 distractors that you can choose from. And why would you do this if you're writing an examination? The reason you do this is because of test grading statistics and analysis, and not getting into that, but essentially the theory behind it is that if we have options from A to double Z, then that allows discrimination of lower ability students, and it can allow the question authors and the question proctors to understand who is a good student and who is a bad student from that type of question. The types of questions that they have themselves follow a couple of different types, one of which is multiple item format. This is where you're given a vignette and several questions based on it. In the multiple item format, you can change your answers, and the questions are, by definition, independent. You can go back and forth. You will recognize these based on a couple of different features within the test-taking software. There will be a title. It appears in gray where it says the following vignette applies to the next 3 items. And there will be a box around the multiple items, and the numbers critically are black. Contrast that to the next type of question. This is called the sequential item format. This is where you're given a vignette and several questions based on it, but you cannot change your answers. You must go through them in sequence, hence the name. The questions may or may not be dependent. And again, these will be identified based on the black box and the numbers. The numbers this time will be gray. meaning that you cannot click, in this example, number 7, without first answering number 6. They will also give you a title warning telling you you cannot go back and change your answer for 6 in 7. It's been my experience that nobody wants to have immediate negative feedback, but thankfully they don't generally tell you that the answer to 6 in question 7. So go through this and answer it and move on. There are ground rules that have been established for the writing of the questions in your examination. And these are a few key ground rules that are important for you to understand. The question should focus on a common or potentially catastrophic clinical problem. The question should assess an application of knowledge and not a recall of an isolated fact. It should pose a clear question, and this is a key point. It should pose a clear question and should be possible to arrive at an answer with the options covered, and we'll get back to that. The distractors should be homogeneous, and they'll avoid technical flaws. Do not expect to see 5th grade multiple choice questions here. You will not be able to use test-wise strategies to successfully answer the questions. The lead-in essentially will give you a whole lot of things about what you need to know, and you have to treat this as a 200-patient clinic. I want you to contextualize your studying and do it in a clinical setting. So now I want you to have a test day question strategy. What are you going to do when you're in there? It's really simple. You read the question and you answer the question. But there are some subtle strategies that we can teach to help improve your ability to do this task. Essentially, what the authors of the questions have been asked to do is construct 1, 2, or 3-step questions. 1-steps are the easiest, where they'll ask you a question, they'll ask you for the diagnosis. A 2-step question presupposes that you can understand the diagnosis and then may ask you the anatomy or management with you understanding what the diagnosis is and the question not telling you that. And then the most difficult question, which is the 3-step question, where they ask you something, you need to know the diagnosis, you then need to know the anatomy, and then they may give you A, B, C, D, E on a cross-sectional MRI and figure out what's going on with that. The bad news is that the majority of the questions I expect will be 2- and 3-step questions, so you really want to contextualize your studying. When you do this, and here's a typical question, when you go into the examination and you have such a long question, you want to have a strategy to get through this in an efficient fashion. So what I want you to do is follow this strategy, which may be a little bit unnatural to start, but with some practice, it can be easily mastered. I want you to start reading the question with the very last sentence. In this particular question, the question reads, the aspirate should also yield which of the following findings? So we're probably thinking about immediately that this is likely a basic science type question. And now we have context to reading the rest. The question reads, a 40-year-old woman reports the atraumatic onset of severe knee pain and swelling after undergoing an uncomplicated elective cholecystectomy 1 week ago. She denies any histories of diabetes mellitus or HIV, but has had occasional episodes of mild knee pain and swelling that have always responded to non-steroidal anti-inflammatory drugs. Radiographs are shown. A knee aspirate yields a white count of 35,000. And what I've specifically done here is I've put that eye over the image, because I do not want you to look at the image until you've done those 2 steps. The next step, I do want you to look at the image, of course, and I want you to do it in a systematic fashion. Look from the inside out. What you want to beware is the fracture missing at the end of the image. A classic example would be a radiograph of an ankle, and the fracture is actually a base 5th metatarsal fracture. So do not miss those peripheral fractures or peripheral injuries. Look at all your images in a systematic fashion. So how to read a question? Read the last sentence first and contextualize the question. Next, read the body carefully and decide and pick out what's important, and then look at the picture systematically by starting at the center and working outwards. So now, let's answer the question. I want you to follow a 4-step rule. Remember what I said earlier about the ground rules. It should be possible to predict the answer without looking at it. And indeed, that is the most powerful tool that you can use to efficiently move through this examination. If you cannot look at the questions, and again, I've specifically placed the I there, if you cannot look at the answers and predict the answer, that is the most powerful way, because if you see it, you simply move on. If you cannot predict an answer, what I want you to do is look at the 5, and if you see the immediate one that is correct, pick it and move on. If you still cannot figure out which of the answers it is, use the strikeout tool in the software and eliminate those that are incorrect. And then if you still can't choose between one or two, 3 strikes, you're out. Take the best guess that you have and move on. So how to answer. Predict the answers before you look at the options. Select the one that you think is best, but check all of the options just to ensure. Eliminate those that are obviously incorrect, and then use your best guess. It is overwhelmingly important that you answer every single question. Do not leave a question unanswered. It is okay to flag it and go back, but I do know of individuals who've been unsuccessful because they have failed to answer questions and run out of time. So our final goal, to establish a preparation plan. The plan is a 6-step plan. You first must know the exam. You then must identify your needs, establish a schedule, find materials, start with your worst subject, and then take an inventory. The recertification examination is changing. In 2016, there were 4 general examinations and then a hand examination that had 255 questions that was taken over to 5.5 hours. The general, the adult reconstruction, spine, and sports examinations were 200 questions for 4.5 hours. They had 120 specialty questions and 80 general questions in the adult, spine, and sports. And in hand, they had 175 hand and 80 general questions. But as of June 2016, the ABOS has announced a 2-year phase-in for significant changes to the recertification examination. I would strongly urge you to go to abos.org and read some of these changes. Briefly, in 2017, the 80 general questions are going away from the adult reconstruction, spine, sports, and hand examinations. What will be replaced in their stead is a 150 question examination in adult reconstruction and spine. These will be solely adult reconstruction or spine questions. The general examination will now be 150 general questions. The hand examination will be 175 hand questions, and the sports will be 175 sports. For hand and sports, you no longer need the subspecialty certification examination. You may elect to take this examination if that is where the majority of your practice is focused on. In round 2, which is the 2018 cycle, there will be 3 additional examinations added. This is going to be a foot and ankle, trauma, and pediatrics examination, and these will fall into line with the other examinations. There will be 150 specialty-specific questions on each of these examinations. The general outline, because this is the only outline that is currently available, has some very important points that will help guide your studies, and this is available on the ABOS website. The first thing I want to point out is that multiple trauma that is non-orthopedic in nature comprises 10 to 15% of your examination, such as traumatic brain injury and other types of non-orthopedic issues, such as ATLS. This is a key area. It's very highly tested. The knee joint is the second most frequently tested area, dislocations and fractures. It is tested more than the hip above, so this is another area to focus on. Areas to not significantly focus time on will be basic science. Only 2 to 4% of the examination focuses on basic science. Things that I don't think will appear are going to be inheritance patterns or other things that may have appeared on the Part 1 examination. The former director of the ABOS specifically said that there's a different focus in the basic science principles for the recertification than for the Part 1 examination. You can see spine only comprises 2%, and I know a lot of you may be cheering in the audience. Spine will only be 2% of a general examination. Tumor will cover 3 to 5% of the examination. So let's identify some of your needs. What is your practice profile? The things that you likely do the most, you probably know the best. What I would suggest is you do a pre-test using a variety of different sources and use those questions to find your weaknesses. And it's critically important that you be honest with yourself. This is a highly personal thing, and I can't give you a rubber stamped, this is how you should do it. I want you to look in your past and figure out what's worked, and more importantly, what has not worked for you, and understand what your plan could potentially be. Have a critical assessment. How many hours do you really have between your practice and your personal life to devote to scheduling to this? What I would recommend against, however, is avoiding big blocks of studying, such as 8 hours on a Saturday. You are trying to cram too much information, and adult learning theory suggests that that is not an effective strategy. A slower, steadier daily approach is more likely to be beneficial based on adult learning theory. You want to find some materials. You want to find 2 to 4 sources and go. Remember, the questions are going to be at least 2 years old. Some will be older. Don't obsess over trying to get the latest, greatest, newest thing, but I would recommend that you find a couple of standard sources and go from there. What I would recommend is that you start with your worst subject. It's easiest for you to start with what you like and are good at, but the problem is you can be doing that for too long a period of time, and this can become self-detrimental. What I would recommend you do is you find an area outside your subspecialty area, or areas that you've identified on your outline, or areas that you've identified in your pretest, and start with these things first. It allows you to be more calm that you've identified these areas and have tackled them already, so they're not a black cloud hanging over your head. It's important through this whole process to take inventories. Do a weekly assessment and be honest with yourself. Change what isn't working, but don't be a chicken with your head cut off and run around in circles. Don't keep changing because you'll never make progress. Take a post-test about 1 or 2 weeks before the exam so that you have time to remediate. Don't take one big test the day before because then you won't have time to fix the areas that you find difficult. So in summary, I want you to be able to understand the question format, learn a test day question strategy, and establish a preparation plan. Moving on to epidemiology and statistics. There are 2 separate areas that I would like to discuss in this topic. Number 1 is going to be some basic epidemiology, and then second will be some basic statistics. Thankfully, you can put your calculators away. There will be no math in this conversation. So let's start with basic epidemiology and 4 areas: study types, levels of evidence, sources of bias, and measures of disease. These are the 4 key areas that I believe are most likely to be tested with regards to epidemiology. Within statistics, we'll talk about hypothesis testing, that of sensitivity and specificity, and also that of power and error. And then we'll also talk a little bit about statistical tests and how to answer that dreaded question about which of the following statistical tests should you do. So let's start with basic epidemiology and study types. How this will come up on the exam. A study is performed to determine the number of people with rotator cuff tears. 1,000 individuals are randomly selected to undergo shoulder ultrasound. This study is best described as which of the following? So this is a classic question that essentially asks you to figure out the study type. You can write that lead or leave that lead-in sentence as is and change the body of it to describe any of the following study types. And so let's talk about what these study types are. The way I like to break these down is by time. If you can figure out the time component of the study that they're describing to you, then you are more than likely going to be able to answer what study type it is. If you find all your information at a single discrete time point, maybe over a week or 2 weeks, like a survey, then that's what's called a cross-sectional study. That's when you gather everything at one point, and a survey is the most likely form of that. If you are doing a case series, you identify your patients today. You may go backwards in nature or you may go forwards in time. And if you go forwards or backwards but you have no comparator, then this is a simple case series. If you do a cohort study, what you've done is you've identified the patients today. You've then found out who's going to do surgery and who's going to do non-op, and you figure that out some way, but you've not done it randomized. You then look at some risk factors, and then you follow them in the future. This is a cohort study. This should be carefully contrasted with a case control study. What we do here is today, we identify those patients who are diseased, and we identify those patients who are healthy. The diseases are what we call cases, and the healthy patients are the controls. We then go looking backwards in time to see what risk factors they had for developing that disease or for why they are healthy. And then we can determine which are the cases and which are the controls, and that allows us to understand which risk factors are most important. This is a case control study. To do a randomized controlled trial, I highly believe it's unlikely that you will have this study described to you because you have to describe a randomization process. So you have patients, you randomize them through some randomized technique, you then randomize them to a new surgical technique or an old surgical technique, and you follow them forward in time. That's a randomized controlled trial. Unlikely to be on your exam. It's too easy. So, there are two other types of studies that really don't involve experiments. They are the systematic review and meta-analysis. And what's the difference? A systematic review is where you start with a research question, you have objective selection criteria, and you perform a methodical search. You then find the papers that you want and you produce a summary. This is a systematic review. The difference between that and a meta-analysis is the statistical magic of combining data into forest plots and other varieties of aggregate data where you take the results from multiple papers and combine them to provide single points of data and then provide a summary. And that is what a meta-analysis is. All meta-analyses involve systematic reviews, but systematic reviews are not necessarily a meta-analysis. So we've talked about the study types, but where do they fit into the levels of evidence? Again, some of you who've been following along closely have noticed that the JBJS recently changed their levels of evidence. I do not believe still that this is valid or going to be tested on your exam. I think it will still follow the more widely used standard levels of evidence. So how this will come up on the exam. A study is performed to investigate the outcomes of single row versus double row rotator cuff repairs. The charts of 100 patients who underwent each type of repair are reviewed. What is the level of evidence provided by this study? So you can see this is a two-step question. They want you to figure out what type of study this is, and then they're asking you the level of evidence provided by this study. So there are 5 fundamental levels of evidence, levels 1 through 5. And this is the general way to remember it, randomized controlled trial all the way down to expert opinion. It all gets back in my mind to time again and then experiments in nature. If the study is going forward in nature, generally speaking, this is going to be either a randomized controlled trial or a cohort study. So if they want you to determine between level 1 and level 2 study, what you need to do is determine, have they described a study that has randomization in it? If not, and it's a study that's going forward in time, it's typically going to be a level 2 study. And that's where I think that they could potentially ask a question. They won't ask you to identify level 1. It's too easy. If there is some form of experimental process going on, but you can't quite figure out, and it's retrospective in time, which is why it's gone to the left side of the screen there, then it's likely to be a case control, and that's going to be a level 3 study. Case series and expert opinions, I don't think they'll ask because that's too easy. So, If it's experimental in nature, it's going to be levels 1, 2, or 3. And if it's going forward in time, it's either going to be 1 or 2. And where I'd anticipate them to ask the question is for you to differentiate a level 2 study from a level 3 study. So focus your studying there. A question that may theoretically come up is a meta-analysis is only good as the data that goes into it. So if you have a level, you do not think that a meta-analysis is automatically level 1 if they've included a lot of level 4 data. If they include level 4 data, it suddenly falls to level 4 evidence. Sources of bias. How this will come up on the exam. A study is performed to investigate whether total hip arthroplasty is superior to bipolar hip arthroplasty for femoral neck fracture. 100 patients are randomized to receive either type of arthroplasty. In the methods, the attending surgeon typically performs the total hip, while the chief resident typically performed the bipolar. This study most likely suffers from which of the following types of bias? So bias is where one outcome is systematically favored over another. And there are 3 different ways, again, using a timing analogy, that we can classify bias. There are hundreds of types of bias within orthopedic research. These are the most frequent, and these are the ones that I think are most likely to be tested. Moving to the area before the examination. A selection bias is where you find patients who differ in their prognostic features. So, for example, what are the risk factors for knee osteoarthritis? Well, let's say you do a survey of total knee patients in the hospital, and then you compare it to other inpatients. This is a bias because those patients who are in the hospital getting their total knee had a potential prognostic feature that is not in the community itself. So you've now got a selection bias. You've selected potentially the wrong patients to determine risk factors for knee OA. Another potential bias is what we call the chronology bias, and there are 3 different subtypes: the lead time, late look, and historical controls. The biases that can occur during the examination are a detection bias. This is where you have a systematic inconsistency in outcome assessment. And it's a tendency to look more carefully for an outcome in one of 2 groups. So for example, if we're doing a study on spinal fusion, we don't want a CT scan or pediatric patients, so we get a single radiograph. But in adults, we do get that CT scan. And we may be able to identify the healing after spinal fusion much more readily in a CT scan. And so this results in a detection bias. A recall bias is probably the single most common bias in all of orthopedic research, and the knowledge of a disease alters a recall. And all of you have experienced this in your clinics. So if you provide a survey on risk factors for OA and you find the patients who have osteoarthritis in their knee, almost all of them recall that old football injury or that old pothole that they stepped in as a teenager, and they think that that injury is what's caused their knee osteoarthritis. But if they don't have OA and they don't have a knee that bothers them, rarely, if ever, are you going to remember those dings that you had in the football season as an adolescent that may have caused something in the future. Performance bias. This gets back to that question. This is the systematic unintended difference in care. So if you have a total hip and a bipolar for hip fracture, this has happened in the literature. The total hip's done by the staff, the bipolar's done by the resident. Well, there may be a quality issue here, and that's a performance bias. After bias is a citation bias, the optimism bias, meaning that you're more likely to publish positive results. Citation bias, meaning that you are more important. And then the conflicts of interest bias. I don't think they're going to ask that question. So, the last section, measures of disease. How this is going to come up on your exam. A study is performed to determine the number of people with rotator cuff tears. 1,000 individuals are randomly selected to undergo shoulder ultrasound. 50 patients are found to have a rotator cuff tear. What is the prevalence of rotator cuff tears? So I promised you that you wouldn't have to do any math, and indeed, you don't have to do any math to answer that question. There are 4 fundamental measures of disease within epidemiology: incidence, prevalence, relative risk, and odds ratio. And we're going to go through each. And I like to use this pool analogy. The incidence is the water flowing into the pool. The prevalence is the depth of the pool. And so the incidence is the inflow. It's the proportion of people developing a condition over a period of time. How are you going to remember this time component? Well, think about this. If you're going to fill up your pool and you turn on the hose for only 1 or 2 seconds, you know you're not going to fill up that pool. If you turn it on for hours and hours, then you will, even if the flow is the same rate, you know that you will fill up your pool. So remember, inflow, incidence, is over a period of time. The pool is the total number of cases in a period of time, and this is prevalence. We don't need to worry about how long it took to fill up the pool. We just care that the pool is full, half full, or empty if we're going to go swimming. So that's how you remember that pool prevalence does not have a time component in it. And so this is how it presents in the literature. Incidence for rotator cuff tears is 10 per 1,000 per year, whereas prevalence is a percentage, or the way that the epidemiologists like to do it, 800 per 10,000. Incidence, inflow, prevalence, pool. That's how you remember it. But now we get to the more difficult concepts of relative risk and odds ratio. And this gets back to the concepts of case control and cohort studies. We want to know what the relative risk factors are, and we want to know which is the most important to predict an outcome or a disease state. How can we figure that out? And we're figuring out how strong the association is between the risk factor and outcome. And so to do that, we use a ratio called relative risk. And it is asking us, what is the ratio of the risk of disease in exposed individuals compared to non-exposed? Well, the way we do that is through this simple table. If you look at relative risk and you look at what the numbers are, then it becomes really easy to interpret. If the relative risk equals 1, meaning that the risk in the exposed is equal to the risk in the unexposed, then there is no association. And so the risk factor for example, drinking milk causing tibial non-unions, there's no association. The number of people who drank milk who developed tibial non-unions was equal to the number of people who drank milk who did not develop tibial non-unions. However, what if the relative risk is above 1? Then the risk in the exposed is greater than the risk in the non-exposed, and this is a positive association. I very specifically put a question mark there under causal because you cannot infer causality from relative risk. It can infer or suggest causality, and we can do further tests or further studies in the future to determine causality, but it suggests risks. Similarly, if the relative risk is negative or less than 1, then what we have is a negative association. And the risk in the exposed is less than the risk in the non-exposed. And this could potentially be protective. This is the question that they will ask you. They will give you a long-winded question. They will tell you that the relative risk is 2.8 and that the 95% confidence interval is between 0.8 and 4.8. And then if you remember from a couple of slides ago, I said that if the relative risk equals 1, then the chances in exposed and non-exposed are exactly the same. So how can it be that the confidence interval is between 0.8, which is potentially helpful, and 4.8, which is potentially harmful? So theoretically, in their 95% confidence range, it theoretically could be 1. And therefore, it is non-significant. And that is the question that they will ask you. And how do you determine risk? Well, risk is calculated by incidence. And incidence is a prospective thing that you can only determine going forward. You can't figure it out going back in time. And remember our study designs. The cohort study is the one going forward in time. So relative risk gets associated with a cohort study, because incidence must be gathered prospectively. So now what do we do with our case control studies? This is now the concept of the odds ratio. The odds ratio are things that we're actually probably more in tune with, like a horse race or a lottery. And an odds ratio, thankfully, follows the same general idea. And we don't need to get into the math because that's not important for this examination. It's simply, rather than the risk, it's the probability that an event will occur versus the probability the event will not occur. And in other words, it's the odds that a case was exposed versus the odds that a control was exposed. And the good news for you guys is you've already learned how to interpret relative risk, and odds ratios are interpreted in the exact same way. So the question is probably going to be relating odds ratios to case control studies and relative risk to cohort studies. And that's what we see here. So moving on to our final section, which is basic statistics. The first thing I want to talk about is sensitivity and specificity, and how this will come up on the exam. Studies performed to investigate the utility of ultrasound in diagnosing rotator cuff tears. 1,000 individuals are scheduled to undergo shoulder arthroscopy are investigated with ultrasound. The results of the investigation are shown to the right. What is the sensitivity of the shoulder ultrasound? And so what they're doing with that type of question is asking you to determine the sensitivity, specificity, positive predictive value, and negative predictive value of a diagnostic study. So let's do this. How good is MRI at diagnosing a slap tear? Tear, no tear on the left there. And then let's presume that arthroscopy is the gold standard, and the top columns will be tear or no tear at arthroscopy. If there is both a tear on the MRI and a tear at arthroscopy, this is a true positive result. The study has given us a truly positive result. If the MRI says that there is no slap tear, and when we scope the patient, they don't have a slap tear, then they have a negative, true negative. They truly were negative. But what happens if the MRI says that they had a tear, and we scope them and they don't? This is a falsely positive result. And then conversely, what if they don't have a tear on the MRI, but we scope them anyway and they do have a tear? That's a falsely negative. And this is a key slide because this enables you to answer all the questions that follow. Sensitivity is the ability to detect disease. It's the ability to detect true positives. If you're having difficulty with some of these questions or concepts, I would recommend you read Review of Orthopaedics 7th edition. Joe Hart's done a wonderful job going into this in significant depth. Sensitivity is calculated with true positives over true positives plus false negatives. So it's same, and total opposite. That's how we calculate sensitivity. Whereas specificity is the ability to detect health, or our ability to detect true negatives. And so it looks like the mirror opposite. It's true negatives over all the true negatives, and then the diametric opposite, which is false positives. Positive predictive value is how likely is it that a person has a disease given a positive test result. Or it's the proportion of positive tests that are truly positive. So here's an interesting issue. We only care about the positive tests here, and that's how we're going to calculate it out. Again, we'll start with the true positives on top. Again, we'll have the true positives on the bottom. And rather than the diametric opposite, we just have false positives. Same deal with negative predictive values. The probability that a person is healthy given a negative test result, or the proportion of tests that are truly negative. And so it's the true negatives over true negatives and false negatives. And so in summary, sensitivity and specificity are same, and total opposite, whereas positive predictive value and negative predictive value are all positives and all negatives. And how they would ask you that on the examination is by giving you the mathematical formula in raw math format, not the actual final answer. So now let's talk a little bit about power and error. How this will come up on the exam. A study is performed to investigate the causes of rotator cuff tears. The study incorrectly ascribes an association between rotator cuff tears and obesity. Which of the following statistical terms best describes the results of this study? So why do we do studies? We do studies because we want to find the truth. The truth being something that we may never truly know, but we think we know. And so let's do an experiment, and let's suppose that we have the ability to know the God-given truth of a certain condition or a certain study or a certain result. And so let's see if the experiment and this predefined truth have an association or no association. This is similar to several slides earlier where we talked about true positives and true negatives. If our study finds no association, and truly there is no association, so for example, if we do a study and we find that drinking milk does not have an association with tibial shaft fracture healing, and in truth there is no relationship, then we've done a correct study. Similarly, if there is an association, and there truly is, that's easy to understand. But what about the falsely positive study where we find an association between something, but in truth there is no association? Or conversely, we find no association, but there truly is. These are false positives and false negative studies. And so these two false studies create error. And the errors are type 1 error or alpha error, or type 2 error and beta error. The type 1 is a false positive and the type 2 is a false negative. How are you going to remember this? Type 1, alpha, type 2, beta, that's easy to remember, 1 in alpha, 2 in beta. Then Dr. Miller taught me a very key point, is if you can remember one, the other is the other. So if you can remember that type 2 is a Roman numeral that kind of looks like the two vertical bars on the letter N, then the type 2 error is a false negative error. And then you'll remember that a type 1 error is the opposite, which is false positive. That's how you'll get through these questions here. Which is worse, type 1 or type 2? We've decided as a scientific community that the type 1 error, the alpha error, is the worst, because this is crying wolf. This is claiming an association when there is none there. And so we don't want to be doing surgeries that are not indicated if they truly are not helping. That's why a type 1 error is the worst of the two. And we only want this 5% of the time. And that's where the concept of p less than 0.05 comes from, because we only want this 5 times in 100. But what about beta? Well, let's go through this simple examination. Let's do this exam. Let's say that I'm on vacation and I see this poster that says that beer is probably good for your health. It gives you strength. And so here's my son and I give him a beer. And this is what he does. He doesn't like the beer. And so I figure in my study that beer does not give baby strength. And I'm pretty confident in my conclusion there. However, suppose God has told us that beer really does make our babies stronger and gives them strength. What I've done is I've done a type 2 error, a beta error, a beer error, and that's okay. If I figure out that my baby probably shouldn't have beer, that's all right. And we're going to live with that 20% of the time because it's a false negative. I've gone and told everybody, I've told my coworkers at work, hey, don't give your children beer because it won't make them stronger. That's probably a good thing at the end of the day. I haven't gone out there and say, hey, go drink beer. But that's why we have 20% as the beta error. And so this gets into the concept of power. Power is the probability of finding a significant association if one truly exists. So some of you who are aware of the concepts of power have probably said, hey, Thompson, you just did a study with one individual. Your study was underpowered. And you're right. And this is the whole concept of power. And so it's how good, how able is our study going to be to find the true positive. That really is what power is. And so the beta error is that area that you see there. And so power is 1 minus beta, or 1 minus that 20%, and that's where 80% power comes from. And so 80% power says that we have an 80% chance of doing a study that finds that P is less than 0.05 if a true association truly exists. What influences power? 5 things. Where we set our alpha level, so 0.05 is going to do that. The beta error, 0.2, these are standard things, but you can change them if you like. And then 3 additional ones, effect size, variance, and sample size. So let's go through these because I think they're legitimate questions to ask. Let's say that we're 20,000 feet up and we want to look down at these 2 bars. If the effect size is very large, it's very easy for us to see from 20,000 feet up that there is a separate green and separate red bar. But if they live close together, then the effect size is small and it may not be easy for us to see that difference. If there's a variance that's very narrow and very far apart, that's also going to help us. This is like looking at the Rocky Mountains. If you're up close, you can see multiple different mountains. If you're far away, they start to blend into one big Bob Ross painting. And if you have a sample size, which is what I alluded to earlier, perhaps you just didn't have the numbers there to actually find someone who had the disease or outcome that you were looking for. That's the easiest one, and I don't anticipate them to ask that question. I would expect them to ask you one of the first 2 there, effect size or variance. So finally, let's get into statistical tests, how this is going to come up on the exam. A study is performed to investigate the outcomes of rotator cuff repairs. The mean Koos outcome score in the surgical group is 75, while in the non-operative group, the mean Koos score is 32. What statistical test would be most appropriate to compare the 2 groups? And what test to pick? This is a lovely table that we worked on for the 7th edition of Review of Orthopaedics that will go through this. And I'm going to go through this with you right now. The first thing we need to do is determine what type of data we have. Do we have what's called continuous data, or do we have what's called categorical data? What are they? Categorical data are based into nominal or ordinal. These are categories. So nominal, boys, girls, they are equal in category, so they are nominal. There's no leveling to them. Ordinal still falls into categories, hurts none, hurts a whole lot, but there's a scale to that. So there's an ordinal scale there. So that's an ordinal type of categorical data. Whereas continuous data follow either an interval or a ratio scale. An interval scale is where the 0 has no real meaning, right? 0 Fahrenheit or 0 Celsius does not mean complete absence of temperature. So this is an interval scale of continuous data. Ratio, however, does have a truly defined 0 point, 0 age. You can't have negative age. 0 Kelvin is reasonable because you can have absence of temperature on the Kelvin scale. So if you can pick out immediately that there is categorical data, then it's really simple because right at the very bottom there, it's either chi-square or Fisher's exact test. And those are the only options, and they will not ask you to differentiate between the 2 of those. That's for a statistician to determine. The next thing that we need to figure out is if we have continuous data, which is the most likely thing that they're likely to present to you, is it's unlikely, highly unlikely, that they're going to give you an abnormally distributed data set. They have to tell you or show you a curve or do something to get into that red box there. But that red box is full of lovely distractors, such as the Mann-Whitney U test and the Wilcoxon sign rank sum test. And those are great things to fool you on. So that's where those things are going to come from. If they have a normal distribution and they show you a graph that looks like this, then we're into the normal section. And this now becomes easy. You either need to figure out how many groups do you have. Do you have 2 groups or 3 groups? Well, if you have 2 groups, you use a t-test. And if you're from New England and you have a bit of an accent, if you're over 2, then you use an OVA test. And so you can see that in the bottom part of the blue box here. If you have 3 or more groups, you use an ANOVA, a MANCOVA, or something along those lines that ends in OVA. And if you have a 2-group test, then it's a T-test. If they're related, then you use a dependent. Simple. And then finally, moving to the last part, what say if you don't have groups that you want to compare at all? What if you want to determine the relationship between 2 variables or a bunch of variables? These are where we get into correlation coefficients and regression analysis. I do not think they will ask you to pick between the 2 of those, but that's where regression and correlation come in. They can, however, ask you about regression, a negative, 0, or positive regression, and what that means. So for example, the easiest thing is the positive regression analysis, which shows that as auto accidents in your career go up, your auto insurance is more likely to go down. We know that the auto body color and the auto quality do not matter, so that's a 0 regression. And if you have a negative regression, meaning that as the mileage goes up, your value goes down. And those are questions that they could potentially ask you. So I wish you the best of luck in the examination, and if you have any questions or concerns, please feel free to email me. Thank you.